Thank you very much, Alpha. Good morning. Let me first disclose my conflict of interest with Pulsion Medical Systems and with Baxter. So, should we go calibrated or uncalibrated? To answer the question, I think that we should ask ourselves 6 other questions. The first is, what is pulse contour analysis? I will not repeat what has been said by Antonio Messina just before, but just remind you the important facts we must bear in mind to answer the question, calibrated versus non-calibrated. You understood that basically pulse contour analysis means that you can estimate cardiac output, cardiac index, and stroke volume by the analysis of the arterial pressure curve. And basically, this is based on the physiological facts that, as well explained by Antonio just before, during systole there is an increase in arterial blood pressure, so the upstroke that occurs during systole dilates the aorta, and during diastole there is this decay in the arterial pressure, in the aortic arterial pressure. So obviously, and no need for a figure to tell that, the waveform and the amplitude of aortic pressure are related to stroke volume. The second fact that is very important to bear in mind for answering the question calibrated versus uncalibrated has been explained as well by Antonio. It's the pulse wave amplification phenomenon. The relationship, as I described just before, is true at the aortic level. But usually we measure the peripheral pressure, which is different from the aortic pressure because of this pulse wave amplification phenomenon. And keep in mind that it basically depends on arterial compliance. The peripheral arterial pressure we measure at the radial, at the femoral level, is different from the aortic pressure. How does it work? Basically, Antonio Messina told us that all the devices that perform pulse contour analysis perform this precise detection of the arterial pressure waveform, and especially, he told us, detect this diacritic notch, perform the geometrical analysis of the curve to estimate stroke volume that is then multiplied by heart rates. That's the basic principle of pulse contour analysis. We have several devices today that use this technique, and of course they work in a different way with different algorithms. I will not detail all these algorithms, and basically we do not know exactly how they work because of course they are kept secret by the constructors. But there are different models, different ways, the 2-3 element Fincastle model, model flow, LTIA, pulse power analysis, PRAM, etc. So different algorithms. But basically, geometrical analysis of the arterial pressure to estimate stroke volume. Just to give you an example, the 3-element Fincastle model, so that you basically understand how it works, the devices measure the arterial pressure, precisely compute the arterial pressure waveform, then estimate what is the pressure at the aortic level, and apply a model based on an electrical analogy of the cardiovascular system that takes into account resistance and compliance of the, and impedance, by the way, also of the system. And this estimates stroke volume and cardiac output. Roughly, it's the way it works. By the way, if you want to have a more precise description of all these algorithms, you should read this very, very nice and well-written review by Bernd Saugel and colleagues. So, what is the advantage of pulse contour analysis compared to other techniques? There are 2 advantages. The first one, you understood that stroke volume is estimated from one pressure beat. which means that these devices provide stroke volume for each arterial beat. So pulse contour analysis provides a real-time, a continuous measurement of stroke volume. Of course, several heartbeats are averaged, and the system's average stroke volume over 12 or 20 seconds, but basically this is real-time monitoring. The second advantage is indeed the precision of the system. As said by Antonio Messina, it may vary from a device to another, but basically these are very precise techniques. For instance, with here the pulsoflex technique, the study by Mathieu Bier showed that the smallest change in pulse contour analysis derived cardiac output you may trust is less than 1%. Echo, it is 10%. The PA catheter and transpulmonary thermolation the same. So very precise. And so it means that these devices are particularly suitable for assessing short-term and small changes in cardiac output, especially during tests of fluid responsiveness. For instance, the end-expiratory occlusion test you have on the screen, directly in real time, the changes in cardiac output. The duration is short, the diagnostic threshold is small. It would not be possible to assess the effects of the test without a continuous and precise technique measuring cardiac output and stroke volume. Then, what is this issue of calibration? As I told you, we have many devices, but all these devices are not the same. Some use an external calibration, hemisphere, pico, lead couplers. Some use an internal calibration, minimally invasive or non-invasive devices, and one device, the MustCare, performs no calibration at all. Roughly, to summarize, because it's a bit complex, usually one speaks about calibrated devices for the externally calibrated devices, and non-calibrated devices for the other ones, okay? Non-calibrated with the MustCare, so all devices are not the same. It's very important to bear in mind. So MustCare, non-calibrated, no calibration at any time for analyzing the arterial pressure curve, continuous estimation of cardiac output. It's very unclear how it works, but anyway. With what one calls the minimally invasive devices, there is an internal calibration, an analysis of the geometrical form of the waveform of the arterial pressure, so the amplitude and the geometrical waveform allows the system to have an internal initial calibration. And after this internal calibration, the system estimates stroke volume beat by beat. In addition, there is likely a continuous readaptation of the system. Pulse control can also be applied on arterial pressure obtained from non-invasive devices. I don't speak too much about that because this will be the topic of Jan Benesch in the last talk. But these devices estimate stroke volume. You may know these devices just with a cuff wrapped around the finger. And it's a very clever way of estimating blood pressure developed by physiologists decades ago. Inside the cuff, there are two things. Inside the ring around the finger, there are two things. There is a cuff, pneumatic cuff, and a plate sensor, plethysmography sensor. As you know, plethysmography measured oxygenated hemoglobin, so the volume of the digital arteries. At each time there is an arterial beat, the cuff inflates very rapidly in order to keep the plate signal constant. And the principle is that the pressure inside the cuff around the finger estimates the arterial pressure of the digital arteries. There is a calibration and it provides you see, a curve. It's not just systolic, diastolic blood pressure. It's an arterial curve obtained with this cuff around your finger. And on the top of that, on this arterial pressure curve, pulse contour analysis is applied. So you have cardiac output just with these non-invasive systems. Then, and finally, we have the calibrated, externally calibrated systems, Hemisphere and Pico, which roughly work in the same way. Transpulmonary thermodilation devices require a central venous catheter in the superior vena cava territory and an arterial pressure, an arterial catheter, which is a very specific catheter because there is a thermistor at its tip, a thermometer. It's a large catheter which is usually inserted in the through the femoral artery. So this is an invasive technique, and we'll speak about that later. These devices, it's important to understand that, estimate cardiac output in two different ways. First, with thermodilution. This is inferred from the old PA catheter. When you inject a cold bolus, analysis of the thermodilution curve provides you a cardiac output measurement which is very reliable, intermittent, and not very precise. In addition to that, because these systems are connected to the arterial pressure, they perform pulse contour analysis because these systems have an arterial pressure curve. Nevertheless, this time, pulse contour analysis is calibrated by transpulmonary thermodilution. What does it mean? They use the three-element Windkessel model. Roughly, stroke volume is proportional to the area under the systolic part before the diacritic notch. But of course, it's not equal. There is a calibrating factor. Okay, it's the ratio of the area of our stroke volume. And calibration means that, very simply, at each time you perform thermodilution measurement, the system knows stroke volume, and at the same time the area. And so it calculates this calibrating, multiplicating factor. And after this initial calibration, external calibration through thermodilution, every heartbeat is estimated by the same calibration factor to estimate stroke volume. With lithium dilution, it's roughly the same, except that you don't use thermodilution. You inject a bolus of lithium, and the system detects the dilution curve, and the same, you calibrate the system for the area under the curve and stroke volume. In many countries, this device is not used because injecting lithium is not allowed, as for instance in France, but many other countries. Finally, one specificity of this minimally invasive device, the Pulsioflex, because it allows you an optional external calibration. If you do an echo and you measure cardiac output, you can enter the initial value of cardiac output in the machine, and from this initial value, it performs then pulse contour analysis. So it's an optional external calibration, not very easy to use anyway. What are the limitations? Basically, the limitations come from the fact that cardiac output is not arterial pressure. And between cardiac output, between the heart and the artery, the peripheral artery, there is the arterial system and its properties. Compliance, which roughly changes with age, so usually not during an ICU stay, but even more importantly, the resistance. Arterial resistance influences the reliability of pulse contour analysis. I showed you the example of the Windkessel model. Resistance is integrated in the model. The system uses the pulse wave amplification phenomenon to estimate aortic pressure, and this phenomenon, as told us by Antonio Messina, depends on resistance. So definitely, these devices are not reliable when non-calibrated if the arterial resistance changes. It's been shown by many studies, just 3 examples. In this study, we assessed the reliability of an uncalibrated system. Volume expansion, no change in SVR. The percentage of error should be below 30, was 48. When we changed the dose of norepinephrine, the percentage of error was much larger. This study of Maxime Canesson, uncalibrated device versus esophageal Doppler. The concordance rate, the proportion of cases where both devices showed changes in the same direction was good when they manipulated preload, worse when they infused ephedrine or phenylephrine. Even more illustrative, the study of Mathieu Bier, you see, during liver surgery, which induces strong vasodilation episodes, the larger the changes in systemic vascular resistance, the larger the bias. Uncalibrated devices are not reliable when the arterial resistance changes. So finally, we can answer the question, calibrated or uncalibrated. These devices should not be indicated in the same setting. The internally non-calibrated devices are for the operating room, high-risk surgical patients, the other ones for the ICU. They are less reliable in septic patients, in patients that receive norepinephrine. They are cheaper than the other ones. 70% of the price of the invasive devices, roughly. More importantly, they do not provide the same amount of information. You know, if we take just the example of transpulmonary thermodilation and non-invasive, non-calibrated devices, with these devices, you only have cardiac output and stroke volume, while the other ones, as you know, provide in addition an estimate of cardiac preload, of lung water, of lung permeability, of cardiac contractility. So they do not answer the same questions. During a surgical intervention, what are the questions asked to the anesthesiologist? Just, should one give fluid, and he or she needs cardiac output and stroke volume variation, pulse pressure variation, and should I give a vasopressor? Use blood pressure. 2 questions only. In a patient with septic shock and ARDS, many more questions are asked to the intensivist. Should I give fluid? Should I not give fluid? How is cardiac contractility? Is there AV dysfunction? Etc., etc. So these devices do not provide the same amount of information. Finally, there is the issue of invasiveness. There are some non-invasive devices, minimally invasive devices that can be plugged on a standard radial catheter, while transpulmonary thermodilation devices require this large arterial catheter. This study years ago showed that the rate of complications is not very high. I'm not sure it's so low because it's an invasive technique, definitely. Sometimes some experts say these are minimally invasive devices. I do not agree at all. There are some arterial complications during the insertion and the removal of these devices. We perform a larger study to assess the rate of these complications. If you want to join the study, please contact me, but these are definitely invasive devices. So, to conclude, these devices do not have the same indications. Some are for the operating room, some others for the critically ill patients, answering all the questions asked to ourselves by these patients. Thank you very much for your attention.